Hi, class. Hope you guys are doing well. We are going to have hopefully not too long of a lecture on just some common cardiovascular problems that you may see or encounter in the psychiatric mental health world. Um, so first of all, I just wanted to briefly discuss common cardiovascular complaints, because so many of them um, can have a psychiatric etiology. So it's really important to look at these. The trick is to determine if these complaints are cardiovascular in nature or not, and if they're severe, or if these are psychiatric complaints. Many psychiatric complaints can present with similar symptoms. Um, Things such as syncope or dizziness is a common side effect of some psychotropic medications. However, you should take note that it can also be indicative of a really severe cardiac disorder, such as a high-end heart block, or cardiomyopathy, or some serious arrhythmia. Syncope can also be secondary to severe orthostatic hypotension, hypoglycemia, or CVA. Chest pain as well has a number of etiologies, which include cardiac disease, but also includes things such as panic disorder, anxiety, post-traumatic stress. Shortness of breath similarly can appear as panic, can be due to panic, but it can also be due to a vascular complaint or a respiratory complaint. Palpitations, again, another one common with anxiety, but can also be a cardiac symptom. So it's really important to kind of tease that out when you're interviewing the patient, and making sure that these symptoms that you may assume are psychogenic in nature are not something more serious. It's important that you know just the basics on hypertension. I'm not going to get into all this, but it is estimated at least 46% of American adults have hypertension, over 103 million, and quite a number with undiagnosed hypertension. So it's a significant problem in the USA. Untreated hypertension, of course, has major risk factors, including cardiovascular disease, stroke, heart failure, kidney disease, and vision loss. If you can reduce that systolic blood pressure just by 10 points, you can reduce that cardiovascular risk significantly by 17%, 27% for stroke. So getting the hypertension treated appropriately can impact health in general. This has really changed over the years. We used to see 120/80 is perfect. But now what's considered perfect is below 120 and below 80. It's considered elevated if you have a systolic blood pressure of 120 to 129. So that is like, wow, that's pretty low. And actually considered stage 1 at 130 to 139, or a diastolic of 80 to 89. That constitutes probably a very large percentage of our population. So what are some factors that contribute to this development of hypertension? Essential primary hypertension, or this is primary or hypertension that has no known secondary cause, remains somewhat of a mystery. The etiology is unknown, but it is thought that endothelial dysfunction plays a role. The endothelium is in a regular state of vascular tone. It regulates vascular tone, structure, and formation of thrombosis and inflammation. So if you think back all the way to pathophysiology, the chronic inflammation, the endothelial dysfunction, and all that it can cause. Because it affects the tone in the vasculature, this can affect your blood pressure as well. Another thought is abnormally high renin levels. And if you have abnormally high renin, this is going to activate that renin angiotensin 1 aldosterone cascade, which can lead to increased blood volume and therefore increased blood pressure. Of course, hypertension does increase with age, and there's really a 90% chance of developing hypertension later, even if you are normotensive at age 55. Um, Genetic and ethnic influences do play a role. Hypertension is more common in the African American population and typically has a younger onset of age when it begins, and a quicker and more severe progression of disease. Males are particularly at an increased risk. Um, Family history can also predispose us to hypertension. Other things such as obesity, secondary to lifestyle, increased salt intake, and smoking are environmental factors that are strongly linked with hypertension. In populations in which these factors are not prevalent, the incidence of hypertension is significantly lower. In addition, increased alcohol consumption, diabetes, dyslipidemia also increase the risk. Those with low vitamin D are also more susceptible. Certain personality traits are more common among hypertensive patients, including those who are impatient or hostile. Um, Hypertension is also linked with depression. So, this is really important when you're talking with some of your patients who struggle with anger management or struggle with keeping their stress under control. It not only impacts their mental health, but it impacts their cardiovascular health as well. I just put this slide in here. I know y'all know how to take a blood pressure, but if you ever, in most psychiatric facilities or psychiatric offices, they do not take them. But if you ever have an occasion to do so, or if you have a tech trying to take them, sometimes they don't follow the exact protocol for appropriately taking one. So I just put that in for that. There are some secondary causes of hypertension. You should always look for these if you have an onset at a younger age, if the blood pressure is higher than 180 over 110, if they have significant target organ damage, like hemorrhages and exudate on the fundoscopic exam, renal insufficiency, left ventricular hypertrophy, they aren't responding to therapy, accelerated or malignant hypertension that's not responding to your treatment. You should always look for secondary causes. One of the big secondary causes is medications. And if you look on this list, you see SSRIs, tricyclic antidepressants are ones that you will be prescribing as psychiatric mental health NPs, but also common stuff such as NSAIDs, weight loss medications, all kinds of things. Decongestants can contribute to hypertension. Illicit drug use is another one you should watch for. Stimulants, things like cocaine and all that can definitely increase it. A few other things here I just put for food for thought are some of the aldosteronism, some other sleep apnea, phenochromoscytoma. I'm not going to get deep into these. Cushing's thyroid, all of these can be secondary causes of hypertension. And don't forget white coat syndrome, which is when you have a transient rise in blood pressure. When a patient's in a clinical setting, they get nervous, they can have a rise in blood pressure, which is just transient. There is target organ damage related to hypertension. Some of the ones you will see as far as the eyes go are papilledema, little hemorrhages, or exudates. You can also see changes in neurological deficits and changes in mental status if it's very high. An EKG might show myocardial ischemia or infarction. They might have heart failure or aortic dissection. It can cause renal dysfunction, which is one of the biggest things that you'll see with poorly controlled hypertension is renal dysfunction, leading to the need for dialysis. So our goal, of course, is to prevent this. There's a cardiovascular risk assessment, which is really good and can be a wake-up call for some patients when they really don't want to deal with their hypertension or their lifestyle. This is a link for a quick little tests you can have patients take to look at their cardiovascular risk, looks at the presence of diabetes, hypertension, some other things that will affect cardiovascular risk. These are the things that it looks at. It looks at the age, race, and gender, which of course they can do nothing about. But it also looks at their total cholesterol, HDL, blood pressure. Are they being treated for it? Are they diabetic, and do they smoke? If someone has normal hypertension, it's recommended that all adults are screened annually. If it's elevated, but not stage 1, it's recommended that they follow up in 3 to 6 months to continue monitoring. Stage 1 hypertension should be seen monthly until that blood pressure goal is met with either blood pressure lowering medications or non-pharmacological interventions. And then every 3 to 6 months after that goal has been met. Stage 2 should be monthly until they have reached their goal as well. Lifestyle modifications are really important and are also important for mental health as well. These are the same things we teach about everything. One thing people are taught is, of course, weight reduction, but also the DASH diet, which is which stands for Dietary Approaches to Stop Hypertension. The diet is really simple and basically says eat more fruits, vegetables, and low-fat dairy foods. Cut back on foods that are high in saturated fat, cholesterol, and trans fats. Eat more whole grain foods, fish, poultry, and nuts. Limit sodium, sweet, sugary drinks, and red meats. So very simple diet, which does include, they also look at sodium restriction. Some people are more salt sensitive than others, but in some people, restricting salt can make a big difference. Of course, smoking cessation, limiting alcohol use, increasing physical activity, and of course, relaxation and stress management are beneficial for individuals. And that's your goal of therapy. For most adults, it is less than 130/80, but for those with high risk, sometimes they would like it even lower. Our pharmacological therapy. The agents on this line are first-line therapies. So you want to look at things such as for the hydrochlorothiazide, want to make sure it's a first-line therapy. Make sure you watch for hypokalemia and sometimes hyponatremia. Very commonly used, especially used first line in African American patients and older adults. ACEs are also a first line therapy used in patients in all stages, those with heart failure, renal disease, diabetes, or any previous MI. It is considered renal protective, so that's really important in a diabetic patient in general, as they already have at risk for renal dysfunction due to their diabetes. The biggest problem with an ACE inhibitor is the cough, which can ensue. You can also have angioedema develop with an ACE inhibitor. So, and it also may be, while it is renal protective, it may be contraindicated if a person has severe renal vascular disease. On these, you want to watch for hyperkalemia, as well as the ARBs, which are angiotensin II receptor blocking agents, and alternate for an ACE inhibitor. Should never be given with an ACE inhibitor because they work similarly. They do not seem to have the risk of angioedema or cough as ACE does, and I currently use this as my first line most of the time. We also have long-acting dihydropyridine calcium channel blockers. They are effective in many populations. They can be contraindicated in heart failure patients. They also are used to control the rate in atrial fibrin flutter. And because they have a vasodilatory effect, they are good for people with chronic angina or things such as Raynaud's syndrome. They are contraindicated in second or third degree heart block. So those are your 4 first lines: thiazides, ACEs, ARBs, and calcium channel blockers. That's what you really need to focus on knowing, but there are a ton of second-line treatments I'm just gonna throw out there just so you have heard about them. There are beta blockers, which you've all heard of. They're not first line, but they can be beneficial. They're also beneficial if you're trying to also control rate in AFib or flutter. Um, they also can be good at controlling symptoms of or at controlling tremors, which may occur with also with hyperthyroidism. They are also contraindicated in second or third degree heart block. The other one we have is our alpha adrenergic antagonists, such as prazosin and terazosin, which are also used for treating benign prostate hypertrophy. Centrally acting medications such as clonidine decrease the sympathetic outflow. They can be really used effectively if you have someone with hypertensive urgency and want to bring that blood pressure down fast, but they do cause drowsiness, dry mouth, increased gastric motility, and have a pretty, if they're used for chronic management, they have a pretty bad rebound if you withdraw them abruptly, so the blood pressure can really shoot up. Another one is things such as direct vasodilators, such as hydralazine. These are what is commonly used in a pregnant patient with hypertension. Aldosterone antagonists, such as aldactone, these are potassium sparing. They're weak hypertensive, but we give those in people with heart failure. You do have to watch for hyperkalemia with them. So if you think about it, you have to watch particularly if somebody is on an ACE or an ARB, which are also potassium sparing, and aldosterone. That can cause some elevated potassiums. On the other hand, if they are on an agent that decreases potassium, such as hydrochlorothiazide, and they're on aldosterone, the two will probably counteract each other in terms of the potassium, and you won't have a problem. Loop diuretics are also used in heart failure and in high doses in renal failure, and also contribute to the antihypertensive effect. They will, of course, lower your potassium. You'll see a lot of drugs and a lot of medications out there where they've taken two of these drugs and put them together to make one so that people don't have to take two pills. So you'll see, for instance, losartan, which is an ARB, combined with hydrochlorothiazide or similar type things. Malignant hypertension, hypertensive urgency. This is whenever you have a blood pressure greater than 180/110. If it is emergency, then there will be evidence of acute organ damage, such as headache, confusion, seizures, double vision blurring, not urinating, nausea, vomiting, oliguria. These people, of course, should be sent immediately to the ED. Hypertensive urgency may have the same high blood pressure, but no symptoms. And sometimes this is treated in the office or in the ED or in the urgent care with clonidine. You probably won't be doing this, but just know that this does happen from time to time. We'll treat it with clonidine, get it brought down to a reasonable level where we feel they can be sent home, and then we'll adjust their daily medications and have close follow-up. If they're having symptoms, they go straight to the ER. So question, you've got a 56-year-old with stage 1 hypertension, no known cardiac disease. Blood pressure was doing really well on an ACE, but the patient developed angioedema and the ACE was discontinued. What medication would be the best choice? Give me just a minute. So let's talk about them. So Coreg, let's talk about Coreg just a minute. What is wrong with that as an answer? Coreg is, for one, it's a beta blocker, so it's not a first line treatment. And would probably not be our best choice. How about clonidine? Clonidine, of course, is not first line. It's a centrally acting agent with terrible rebound, so probably not our best choice either. So our other options are Norvasc hydrochlorothiazide, which is C, and that's a fine answer as well. That's definitely a good choice for this patient. And the other one is losartan. And they used to think that giving someone an ARB who had angioedema from an ACE was not recommended, but they're kind of backing off on that now. So that would not be a wrong answer either. But if you wanted to be especially safe, then answer C would be your best choice. All right, let's talk about cholesterol now. Cholesterol is really an essential component of the cell membrane. It maintains the structure and the fluidity of the membrane. It affects the permeability of the membrane, and it's really essential to animal life. If you remember, plants have cell walls, but these are not present in animals. But in animals, we have the cholesterol that makes up these barriers on the plasma membrane. It's also involved in the intracellular transport, and it's an insulated component in the myelin sheath. So it has a lot of perks. It is a precursor for bile, vitamin D, and steroid hormones such as progesterone, estrogen, or testosterone, and cortisone and aldosterone as well. So cholesterol is not all bad. It's got a lot of really good things. And if you ever find a patient who's got a very low cholesterol and they're not being treated for hypocholesterolemia, sometimes they are not a well person. They may have some underlying bad disease such as cancer. So cholesterol is really important. Dyslipidemia is when we have elevated concentrations of lipids in our plasma, and this is really the most significant risk factor for developing cardiovascular disease. Just a little bit into the patho. I won't get deep into it, but your LDL, which is considered your bad cholesterol, along with its precursor, VLDL, or very low dense lipoprotein. These are what lead to atherosclerosis. So the LDL, enters into the bloodstream through that endothelium, and then it's oxidized, and this causes an inflammatory response. And it causes that the oxidized LDL will then stick to monocytes and T lymphocytes along the endothelium, causing kind of a mess. Those monocytes differentiate into macrophages, and then they start eating up this LDL. But this transforms into what they call foam cells. Foam cells release growth factors that actually encourage atherosclerosis. So too much of this LDL can really cause a problem. And that's the bad guy. The good guy, on the other hand, is the HDL, or the high density lipoprotein. This is excreted from the body, and it does not deposit in the arterial walls. In addition, it helps remove excess cholesterol from the blood vessels and delivers it back to the liver, which is cool. And it also blocks oxidation of the LDL, the bad guy. Is found to not only be, it's a risk factor if it's less than 40, but it's found to be actually cardioprotective if it's greater than 60. So LDL is a good guy. So secondary causes of hyperlipidemia, you want to make sure you rule out these. Remember, you're going to be giving them medications such as second-generation antipsychotics, which can contribute, which is why it's really important to check that before you give these medications. See where they are with their cholesterol. These are a lot of things that can be ruled out just by asking questions, but asking about their diet. Is there hyperlipidemia due to obesity and diabetes, or thyroid disorder, to nephrotic syndrome or some kind of chronic renal disease, to liver problems, pancreatitis? Excess alcohol consumption is a big one, as excess alcohol particularly raises your triglycerides. So that's a problem. Do they have issues with their glycogen storage? Are they taking supplemental estrogen? Are they pregnant? Because pregnant people usually have high cholesterol, which is fine. Some of the medications, in addition to our second generation antipsychotics, are things such as thiazide diuretics, which are over here giving for hypertension, and beta blockers. We usually don't find much of a problem with those, but the second generation antipsychotics you do have to watch and just needs to be monitored. When somebody is thought to have hyperlipidemia or they have it, just a good history needs to be obtained of any risk factors they have with cardiovascular disease, their family history, their medications, how much alcohol they drink, their diet, their menstrual history, and how much physical activity they are in. An easy way to look at someone's diet is to ask the CAGE questionnaire, which is really down and dirty way. It's also a good way to help people just pick one thing to change. And what this questionnaire consists of is C, which is cheese or other dairy fat items such as milk, ice cream, cream, animal fats, hamburgers. Oh, no, wait, I'm sorry, that's A. Any cream, high dairy products high in fat. Second one is A for animal fats. Do they eat a lot of hamburgers, hot dogs, sausage, fried food, fat cuts of meats, bologna, things like that? G is guided away from home. Eating out is a huge risk factor. Most restaurant foods are high in fat, salt, and sugar. That is why they taste so good. And E is extra commercially prepared snacks, such as candy, cookies, pastries, pies, donuts, are all high. So sometimes when you ask these questions and talk to a person, you can convince them to change one thing. Maybe they're like, oh gosh, I eat out all the time. I think I'm going to stop my eating out once a week. That in itself could make a difference. Or I'm really eating a lot of junk food, of junk snacks. I'm going to cut that down. Sometimes making one change is something easier for someone to deal with. And this CAGE questionnaire can quickly help you identify where their problem area is on a quick level. So dyslipidemia is considered, if you have what we want is a total cholesterol less than 200, an LDL less than 100, triglycerides less than 150, and preferably an HDL greater than 60. They keep going back and forth whether they want specific numbers or not, but that seems to be the standard. Of course, we know our risk factors for cardiovascular disease. We've already talked about those, but some additional ones we haven't talked about are having that low HDL, and then having a family history of premature cardiac disease in a first-degree relative or other risk factors. Our goal here, of course, is to reduce their risk. So we want to really look at people who already have atherosclerotic cardiovascular disease, those who have a really high LDL of 190, anybody who's 40 to 70 with diabetes, even if they don't have heart disease, or if if their LDL is 70 to 189. We want to pay attention to those people because they have other risk factors. And then people without cardiovascular disease or diabetes, but with an LDL of 70 to 189. And estimated 10-year cardiovascular risk of 7.5 or higher. Basically, we're looking anybody who's got a really high LDL, they already have cardiovascular disease, they have a diabetes, and their LDL is somewhat elevated, or they have other risk factors. We want to be aggressive in their treatment. Clear evidence, there's clear evidence that lowering your LDL will reduce your risk for cardiovascular events. And both patients who know they have cardiovascular disease and those who only have risk factors. So we know that it helps. Of course, we always have our lifestyle modifications, which are the same as all of them. More info there. And then we have our pharmacological treatment, in which the mainstay of treatment are statins. And basically what you should get out of all this without making you crazy is that anybody with cardiovascular risk, uh, with cardiovascular with LDL greater than 190 and cardiovascular risk, with diabetes, no, not with diabetes, with a 10-year risk greater than 50, they should all be on mostly either high, or you could go to moderate if you want, if their risk is a little less. Intensity statins. We no longer do low dose statins. That is what they should get. So really, it's almost anybody with an elevated LDL. If you had somebody and they were 40 years old, they didn't have cardiovascular disease, no diabetes, and they didn't have a 7.5% increase, you could go with lifestyle management to start with. But if that doesn't work, then a statin is the answer. I'm going to talk about statins a little bit more, but just these are a few other medications that we also take for dyslipidemia. Some people don't seem to be able to tolerate statins, though overall their side effect profile is extremely low. But as you can see, they are really good at reducing your LDL and actually increasing your HDL. Some people who have specific trouble with their triglycerides, because you'll find some people like that, they may be taking something like nicotinic acid or fibric acids. As you can see, they have a really good profile in reducing particularly our triglycerides. So statins, this is just a list of high and moderate dose statins. I don't expect you to memorize these. Just know that there's high and low dose. The end of the name is statin, and you should know that. Just a little clue on statins. There's a lot of talk about statins causing musculoskeletal problems and rhabdomyolysis and all that stuff. The truth of the fact is that out of everybody who's on aspirin, you should expect 25 hemorrhagic CVAs per 1,000 patients. And those same 1,000 patients, you will get 2 cases of mild rhabdomyolysis. You will not get any liver failure. We will not have deaths. And the aspirin, you'll have 130 GI bleeds annually. So while people talk about statins, they're actually extremely safe, very low side effect profile, safer than aspirin. So a lot of people avoid them. Now, what do people complain about? They complain about myopathy, muscle aches and pains. That's their biggest thing. The other things you have to worry about are increasing liver enzymes, though there's no documented cases of liver failure related to them, but we should monitor their liver enzymes before starting them. They can result in increased glucose. So, something to watch for, though, of course, we want to get our cholesterol down. So it's important. There's talk of possible cognitive impairment, though they have not been able to prove this, but they are contraindicated in liver disease and in those who already have pre-existing elevated liver function tests. So what do you do if somebody comes in and they're complaining of muscle aches and pains, and that's called myalgia. If it's myopathy, that's when they have myalgia plus their serum CK is high. Rhabdomyolysis, their serum CK is much higher. And they often have an elevation in creatinine as well. So what do you do for this? When you're looking at this, the first thing you want to do if somebody comes in with myalgia is you want to rule out any secondary cause. Are do they pull a muscle? Are they having aches from something else? Um, if a patient has intolerable myalgia or in rhabdomyolysis, then the statin should be stopped. But if they have moderately elevated CK and tolerable symptoms, then you could consider resuming their statin at a lower dose. You also could rule out a secondary cause, like we said. Another option is switching to a different statin or lowering the dose. Some researchers are strong proponents of coenzyme Q10 to take with your statin to help reduce myalgia, though the efficacy remains debatable. Others are strong proponents of taking vitamin D or red yeast rice to decrease this. So basically, if they have a lot of muscle aches, you can't find a secondary cause, you can lower the dose or switch to another statin. You don't stop it unless it's just completely intolerable or they're in rhabdomyolysis. So when you're making a decision about statins, of course, you're gonna look at their 10-year atherosclerotic cardiovascular disease risk, review other risk factors, look at lifestyle changes that are needed, look at the benefits for statins and potential adverse effects. What are their preferences? And consider starting them on a statin. We also have familial hypercholesterolemia, which is a common genetic disorder affecting about 5% of the population, particularly those who are French Canadian and Dutch. They will often have twice the cholesterol levels by age 2. So they are a great risk of premature coronary artery disease with an elevated risk of 20-fold if they left untreated, and can have myocardial infarctions in their 30s. Many of these are only about less than a third are diagnosed, and only 42% are treated. So important to catch this and treat it. If they have this type of hypercholesterolemia, there's no, not that you don't encourage diet changes, but that is not going to be enough. Their cholesterol and everything will be very elevated. Lastly is metabolic syndrome, which that's what we're monitoring for with these second generation antipsychotics. We're looking for what is their weight? Are they gaining weight? And you particularly look for that central obesity, which has been shown to increase cardiovascular risk. That is those with elevated BMI and their waist circumference is greater than 35 in women and 40 in men. Central obesity. You're also looking for triglycerides, their HDL and HDL. Is their HDL good and high? Is their LDL low? What are their triglycerides? These individuals with metabolic syndrome also have elevated blood pressures and elevated fasting glucose. So these are the things that we're really looking for with their second generation antipsychotics. We're looking for their weight to go up. We're looking for their cholesterol and triglycerides to go up. We're looking for their blood pressure to go up and their glucose to go up. And that's what we're hoping not to happen, but that's what we're monitoring for. All right. Hope that wasn't too fast. Thank you.